Dr. Edwin Francis is a pediatric cardiologist, specific focus in interventional cardiology, working as a consultant pediatric cardiologist from Amrita Institute of Medical Sciences. I request Edwin to give a talk.
Good afternoon, everyone. I thank the organizers, Dr. Dagesh Rao, Dr. Srinivas, for inviting me for this session. I think I'm supposed to talk on stenting of the aorta and the other in congenital heart disease. I think I'll stick to the, because of timing, to the stenting of aortic coarctation alone. I'll talk on the agenda today, who can do it, the case selection, pre-procedure imaging, the procedure per se, complications, special scenarios, and follow-up. I don't think I'll focus on all, but I just touch upon the main, especially the procedure planning and how you go about it. I don't think I cannot decide on who to do it, but majority of the aortic stenting, as I say stenting, it's not balloon dilatation. It is predominantly done in older kids. So I think anybody who has a good adult cath lab can go ahead with the procedure. Ideally, you should have a good surgical backup. And in rare situations, in small children, it can even help saving lives, even though you don't have a surgical backup for a pediatric setup. For the case selection, I'm not going to the indication per se. The Class 1 indication given by in 2011 AHA guidelines states that the stent placement indicated in patients with recurrent coarctation who are of sufficient size for safe stent placement in whom the stent can be expanded to an adult size and who have a transcatheter gradient of more than 20. I think they don't mention about the exact size, the cutoff weight or age per se, but they just say that it's adequate size, but it keeps it open. So it's a good measure, I think, is you should go at more than 10 kilos, 10 years or more than 20 kg. It's probably ideal to go for an aortic stenting. Again, I specify that it's for stenting, not for balloon dilatation. And when there is a good antegrade flows are present and when the gradients are more than 20 millimeters. You can have exceptions in all, because in a severe LV dysfunction, a patient or a newborn in shock, you may not have more than 20 gradient. In few cases, you may not have antegrade flows from the ascending aorta, descending aorta, still may go ahead. But these are the classical indications. I won't go into this details, go into the few contraindication. Again, I say as a relative, when the criteria are not met, again, the reasons, there are a lot of large collaterals in an adult patient which may not have enough pressure gradient, or in a pregnancy, it is usually not indicated. I have done recently a case in which a 28-year-old refractory hypertension had to go ahead and do it, and relatively, again, a renal failure. The pre-procedural workup looks very basic, but I think if you miss out any of this, you may end up having trouble. A complete physical examination, BP measurement in all 4 limbs so that you don't miss out aberrant right subclavian arising, so that you know what is exactly the anatomy roughly, so that before you go for the imaging. And do a proper echocardiogram, including a suprasternal view, because it's not often done in adult cardiac setup. In the usual echocardiogram, look for any associated bicuspid aortic wall, is there aortic regurgitation, aortic stenosis, and suprasternal views for this, a good antegrade flows are there or not. Pre-procedure imaging, either a cardiac CT or an MRI, is quite useful. I won't say essential, because many times I skip it personally because of the financial other reasons, especially who have borderline renal functions. If you ask for a CT with again contrast, you can increase the contrast load. But when you're starting off a program in congenitals or structural lesions, it's almost imperative to better to have a good CT imaging so that you can plan your procedure well in advance. Assess the anatomy and the arch branches, and you have the measurements taken and specify the distal arch, transverse arch, the separation of the left subclavian from the coax segment, and the length of the coax segment. These are the critical measurements. If you have it, you can plan the procedure very meticulously. Just for example, is a cardiac CT in a patient with a coarctation, in which you can see this is the first arrow indicates a distal transverse arch with a normal size, where it is normal. You have the coax segment, here the descending aorta, and the descending aorta at the level of the diaphragm. Given indicators like that, the measurement of the descending aorta at the level of diaphragm have given quite importance in many studies, previous recommendations, in which the stent to be placed was measured by the size at the descending aorta. But I personally go by the measurement of the distal transverse arch. When it's a normal, I take it as the measurement for the stent deployment. But in complex scenarios in which there's transverse arch involvement, this the descending aorta, the transverse at the diaphragm could be a guideline. This is another image in the CT image. So these other measurements are routinely made, like when I ask from the technician to measure it, they immediately go and measure the coax segment, which the width of the coax segment is of no major importance, but some recommendations say you can only go up to 3 to 4 times the size of the coax segment, but it's again relative. The descending aorta distal to the coax segment, which is obviously dilated, and we don't try to measure it and try to achieve the size of the descending aorta at that level. And as I said, the descending at the level of diaphragm, which may be a measurement which the balloon or the stent to be deployed. But I prefer the distal normal aortic transverse arch. The procedure per se, it's predominantly femoral, as a radial access may be needed in routine, sometimes not in routine cases, but in specific scenarios in which you need to accurately position the stent, especially when you're using a covered stent, and the length landing zone from the coax segment to the subclavian is minimal, then it's better to have a radial access so that it can guide you during the procedure. And especially when you don't have a long, I tend to use a Mullins sheath. If you don't have a long sheath to guide you for angiograms, it is probably better to have a radial access so that you can plan your procedure better and position the stent better. Whenever in similar case in which the antegrade flows are hardly there, then you have to have a radial access. Or especially when a small kid or a cardiogenic shock, probably there is no femorals palpable, you have no other choice but for axillary or radial. Angiograms are as routine as you do an AP view or a lateral view. Preferably use a Parker pictorial so that you can have clear measurements made. But if you already have a CT measurements, then you may not need it. This is a classical example in which you have a PA angio in which, as you know, the aorta goes posteriorly. You're unlikely to open up the arch better in this view. So obviously you have to go for the LAO, steep LAO or a lateral view to open up the arch beautifully. So here you can see it quite clearly that here is a postoperative patient, so his subclavian is not seen. So you have a good landing zone from the distal arch branch and the coax segment so that you have a reasonable area, you can go ahead and stent the arch. So then before you stent it, the question is which stent you're going to use. The commonest stent available is a Palmer's Genesis or a EV3 or a CP stent. And coming to the covered stent is either an atrium stent or a covered CP stent. The covered stents I have experienced mostly with an atrium stent alone. In other one, I more often use a Palmer's Genesis. It's slightly more cheaper than the CP stent. It has that flex design in which the newer forms of Palmer's Genesis XD doesn't have significant narrowing, like the width doesn't come narrow, the length doesn't narrow down when you inflate beyond a point. Most of these stents are designed to dilate up to 12 by the FDA approval, but you can go up to 18 millimeter. But beyond that, at 18, there's around 30-35% narrowing of the stent occurs. So you'll have to position the stent in according to the stent type you're going to use and to the what width you're going to inflate the balloon or the stent. I mean, the covered stent, what are the advantages of using covered stent? As an overall recommendation, they say the covered stent may be better when you're doing a coax stenting because you're going to inflate a balloon. If there's a chance of rupture or a dissection, a covered stent is going to completely cover it. So it's more safer, probably the recommended stent, and long-term aneurysm formation is almost not known with the covered stents. What are the disadvantages here? The more often is, in our situation, is more of a financial issues. It's almost double the cost of a normal non-covered stent. It may occlude if the side branches come out very close to it, don't have a good landing zone, or especially when you're doing such a middle aortic stent on a long segment, you have to be careful about occluding the spinal arteries, causing paraplegia.
End up doing again redilatation 6 months to 1 year. So most of the children, they are getting gradients of around 40 to 45 millimeters of mercury over the period of time. Don't know, I want to know your experience of it.
Actually, if you look at the literature, the stent which has the highest radial strength is the Palmer's stent.
308, older generation.
Older generation, but nobody uses them because of its pointed.
The more flexible it becomes radial strength comes down. It's basically inversely proportional.
So that's the problem, and people have stopped using this Palmer stent, which has the highest radial strength. There are 1 or 2 stents which are not available in our country, and the open cell design, which is supposed to have the shortest shortening, that's not available in our country, unfortunately.
Of which in India, the CP stent is the best one with the maximum radial strength. So
and the minimal shortening.
Minimum shortening. So the newer XD has only a 10% shortening at 18 mm.
The Max XD has the minimal shortening because of the open cell design.
These Genesis, they have to almost 30% shortening at 18 mm. So you have to plan it accordingly.
Thank you.